today's webinar. Today's session is titled Interventional Radiology in Patient Care, and we'll be looking at what interventional radiology is all about, giving what it is, looking at what it can do for our patients, and looking at the future and see what lies ahead and what other things can interventional radiology do. I'm honored to present this great team today, who are my mentors and teachers. We have Dr. Mugambi, the head of the IR unit in Kenyatta National Hospital, and he'll give us a brief overview and introduction to interventional radiology. We also have Dr. Wangari, who will take us through a few real-life cases that have been done to see what the potential of IR is. And we'll also see what Dr. Murai has for us in terms of what the future has for interventional radiology here in Kenya. And we also have our valued member of the team, Virginia, who is our nurse in charge in IR here in KNH, who without her support and coordination, most of these procedures that we'll be talking about today will not be possible. So please join me in welcoming our first speaker, Dr. Mugambi. You can take it over, Doc.
We are going to really talk about IR on a briefing about IR and patients' care. And I'll take you through a brief introduction of what IR is, because actually this is not something which has been in our country for long, but the rate at which it's growing and the service is providing the patients in terms of supplementing the patient's care and either diagnostic or therapeutic procedures is very, very, very important. And first, I'll start by really defining what IR is. It's considered a subspecialty in diagnostic radiology, but now it's a discipline on itself. So on its own, offering minimal interventional, minimally invasive procedures using image guidance that often replaces or supplements open surgery. The use of image guidance percutaneous procedures has significantly reduced the mortality and the morbidity of the patient, with procedures requiring major surgery are now being done under conscious sedation, mostly on outpatient basis. The thing to note there is image guidance and minimally invasive procedures. Next slide. What does it take to be an IR? We need, in our country now, we need to have a MBCHB, that's a Bachelor of Medicine and Bachelor of Surgery, Masters in Diagnostic Imaging and Radiation Medicine or equivalent, and a fellowship in IR. This IR training depends on the varied durations of how the training is. You can decide to go for 6 months training. You can go for 12 months training and 2 years training for IR. Currently in our country, we have a 2-year fellowship training, which is run in conjunction with KNH and University of Nairobi. But there are countries who can train, where you can train as an IR after undergraduate. Currently, the current ongoing training is here in our country is a 2-year fellowship training. We do review patients in the ward. and perform IR procedures and runs a weekly clinic. That's in KNH. The main sections in IR, we have the body, vascular, neuro intervention, and now we have oncology intervention. In our country, we have 4 IR. That's what I'm talking about in KNH. We have 3 who are trained IR, 3 from KNH, and 1 who runs the faculty from UON. You can see my video is, I'm dark, so. And in every, on a year basis, we always have 4 fellows. Next slide. KNH was founded in 1901, and it's the largest national referral hospital. And we partners with UN College of Health Sciences. The concept of IR was introduced in 1990s here in our country, but it's really taken on. And in 2023, we did over 18,000 procedures. And the variety of these cases included image-guided biopsies, nephrostomy insertion, ureteric degestenting, biliary drainages and stenting, drainages and vascular procedures. Also, either the diagnostic angiogram, TSC, angioplasty, and we run a weekly IR clinic on Wednesdays. And we have 2 operational IR rooms in KNH. IR practice requirements, it's essential for IR to be practiced in a MDT setting, though not always practical for procedure, which, or for the procedure to be subjected to MDTs, like cases which require emergency attention. It's also essential to involve the onward referring or the referral team. Next slide. Right. Okay, IR practice requirements. We need a CT beam, cone beam CT, which takes serial X-ray combined with fluoroscopy. We also require conventional CT, ultrasound fluoroscopy machine, and the devices. And they did the IR suit, and then the specialist themselves. Here in the first image, you can see a very nice machine that is that's a cone beam CT angio machine, and we have a CT scan, and then we also have an ultrasound. Those are really, especially in KNH, these are the ones, the 2 of them, we are relying them on them so much. And we have the specialist. Next slide. Interventional radiology clinic is either we get patients either vertical or horizontal referrals. What I mean by vertical referrals is patients who are referred by your colleague who knows what you do. Horizontal referrals, maybe you treated a patient who had fibroids and then now tells his friend who has the same problem, and the patient we treated now refers them this friend to you. And then you have vertical referral where you get referrals from our colleagues, the ones we work with. We have ward patients in KNH. We have gen wards and KPCC. And the patients from the wards are reviewed by the IR team and appropriate lab investigations. Imaging is requested prior to booking the patient for the procedure. Okay, this is a flow chart. We have the consultation. We do the counter signing. We book the patient so that the patient comes for review in our interventional radiology clinic. And then when we are reviewing the patient, we do the investigation, like the lab works, and maybe you can ask for an extra imaging. Lab works include full blood count, UA electrode, depending on this one is based on case with it's based on what we really want to. So the patient, if a patient has issues with the we are going to do maybe a vascular intervention. We really want to have UA electrolyte, a hemogram. INR is very important. Liver function test. And then when you book for the procedure, either as inpatient or outpatient, we do the procedure and then we do follow up our patient in our clinic or by the referring discipline. Now, let's get to the booking and we reanalyze the same because, for example, you may come for you've been sent, especially now you sort out all the patients, including our staff in KNH, and you think it would be a walk in the park. No, it's not a walk in the park. We have to see you and order for the relevant investigations. Next. Higher procedures include supportive procedures. These procedures do provision of we do supportive procedure for definitive treatment, but not themselves directed treating the or modifying the tumor effect. For example, we might take a biopsy, we do a diagnosis, and then it comes to us that we have also to get into supportive procedures where we really have to do some embolization of the tumor, or once you get into other issues, we really have to do something so that you can get the appropriate treatment. Like, for example, image guidance, insertion of enteral tubes, then cover filter insertion, enteric stenting, biliary drainage, nephrostomy, and ureteric stenting. And then we have new adjuvant embolization, like a portal-vein embolization, where we find that the portobiliary team, they have to do dissection, and we have to embolize one of the vein, the portal vein, the hepatic vein, so that we can encourage the growth of the remnant liver. And also we have those, include those supported procedures. We have ablation, we have CVC insertion, PICC, and hemodialysis catheter. These ones, definitely you may find that you may not get the appropriate treatment till IR are able to sort you on this. Huh? And then we have disease modifying procedures. This the intent is to modify the disease progression, and this modify the prognosis. You give an ablation, TACE, that's transarterial chemo ablation, especially when you have a hepatocellular carcinoma. We have TARE, that's transarterial radio ablation or embolization. And we have isolated perfusion chemotherapy. Then we have therapeutic procedures. And the intent is to treat a condition. Example is endovascular cerebral aneurysm, coiling, bronchial artery embolization, and uterine fibroid embolization. Next. I think with that introduction, we can get to the next presenter, then we see some few cases. Dr. Wangari?
Skip the usual cases that most people know about. I know most people know that we do biopsies of lesions, usually ultrasound or CT guided, and we do drainage of fluid like ascites, effusions, and abscesses. which is image guided, of course, being beneficial to the patient in terms of reducing hospital time admission, and we do it under local anesthesia so that we don't have to patients don't have to undergo sedation unless necessary. So I thought I would highlight some of the more advanced cases that we do, and I'll just give you a list as I just before I start. Okay, we moved right on to it. So the first case was a 20-year-old male. We saw this patient in Kenyatta, was referred to us by the ENT department. This young man had nasal blockage, which was worsening over time, and he was having severe recurrent epistaxis. So he was referred to us from ENT for pre-surgical embolization. And what you can see there is a CT scan, a sagittal view of the head with of the neck with contrast enhancement. And in this area, I hope you can see my cursor, in the area of the, yes, the posterior, the nasopharynx, you can see that mass that is quite large, enhancing with some extension into the sphenoid sinus. So we were, next. This is just an axial view of the same lesion. Next. And a coronal view of the same lesion. So this is usually what we call a juvenile nasal angiofibroma. It is a benign lesion or with where the patient has abnormal vascular channels, and it can actually cause quite torrential bleeding that can even be fatal. So what we were supposed to do was a pre-surgical embolization in preparation basically in preparation for surgery. And this we do for many other tumors where we basically, embolization is basically blockage of the blood vessels. And so the surgeon has a much easier time during surgery, a less bloody field, so they can see better. The tumor margins are also clearer because the tumor will be devascularized. Next slide. So here we were able to go through the transfemoral route. That means we went through the common femoral artery, and we use our items there, the sheath and the catheter and the guide wire. And during this procedure, he was actually having a bit of difficulty because of he was still having nose bleeding, and the bleeding was going, through into the throat. But we were able to embolize still. If you move on, we used what we call PVA particles. These are some tiny particles that we give into the arteries, supplying the tumor. Next. And I don't know if you can play those videos. If you go to the first slide, the first image. So that is a first image, and you can see a catheter right here. And this is the internal maxillary artery supplying the tumor, and you can see the tumor blush in this region. And if you go to the last image and play that, this is after giving the particles, what we call the PVA particles, and you see there's absence of that tumor blush. So immediately, right on the table, the patient stopped experiencing the nose bleeding. Next. And the surgeons were kind enough to send us photos of the tumor, what they were able to excise. And you can see they had from their words, they had quite a bloodless field in such a small space. It made surgery very easy, and that's the lesion there. The patient has been well since and has not been back to us. Next. The next one is a 41-year-old female. She came in 2019 with acute bleeding intra-abdominal bleeding, and this is because she had what we call a left renal angiomyolipoma. Angiomyolipoma is also a benign lesion, but having abnormal vessels within it with small pseudoaneurysms. And so beyond, once the tumors get to at least 4 centimeters, they have a high risk of bleeding. And also being a female gives her a higher risk of bleeding. So this patient had bled, and she had other comorbidities, and the surgeons were hesitant to go and remove the kidney. They wanted to preserve her renal function, and so she was referred to us for embolization. And we were able to do this successfully. Next slide. So here you just have some axial images and of a CT scan that was done on her. This is her right kidney. And if you look at the opposite side, you can see the kidney here has a lesion within it. This hypodense lesion with fat components, and you can see a large hematoma in the retroperitoneal region that is actually elevating the kidney right off the abdominal wall there. And if you go to the next slide. So by the time she came to us, she was having active bleeding, her HB was going down, and she was receiving multiple transfusions. And here you can see in the first image, you can see a catheter that's coming in into the aorta, and we are able to give contrast and outline the renal vessels. And then once we outline the renal vessels, we direct the catheter into the left kidney, and you can see in this lower pole of that kidney, you can see that the upper pole has relatively normal blood vessels, but in the lower pole, you can see the vessels are abnormal. You can see that tumor blast. You can even see the pseudoaneurysms there. So we were able to embolize with what we call lipiodol and alcohol, and the bleeding stopped, and she still comes to us for follow-up, but she's had no issues since then. The tumor has, of course, reduced remarkably in size. Actually, it's calcified by now. Next slide. Another case, we had a patient who came to us, a 63-year-old male, who came as an emergency from accident and emergency. He had just been received from a hospital in Thika, having bled massively through the left hand. He had an AVM of the hand, so the hand was enlarged, and he had some auto-amputated digits because of that, the growth of that AVM. And so the AVM had started bleeding spontaneously while he was at home, and he had received several transfusions from the referring hospital. So by the time he came, he was in fair condition, but quite pale, and he had a large pressure bandage across the left hand with a tourniquet. Actually, he had two tourniquets to try and control that torrential, massive bleeding that was coming from the hand. Next. Next slide. Yeah, so here you can just see this CT scan with 3D reconstruction. This is his right hand. You can see the normal anatomy of the vessels. And then when you look at the left hand, you can see that the axillary, the brachial, the ulnar, the forearm vessels, that's the ulnar and the radial arteries and the interosseous are huge. And then you can see that large mass of abnormal vessels within the hand, and you can see that you can't see the digits. They had auto-amputated previously. So when you play this video next, this is how it looked like. You can see our catheter at the top here, and you can see that abnormal meshwork of blood vessels at the wrist joint and the hand. The next video. And that is how it looked. And what we did is that we started going into each blood vessel that was supplying the arteriovenous malformation, and were able to give our embolization material. In this particular case, we used onyx, something called onyx, And we also used coils. Coils are just some metallic, it's a metallic, basically a coil that we put into blood vessels to close it. And so you can see we do it sequentially. And so you can see the first blood vessel has been blocked there. So, but the AVM is still filling from the other blood vessel. And if you go to the last slide, so we basically will go sequentially into each vessel, blocking it off until we get hemostasis. And you can see the coils within the blood vessels. And in this last image, you can see you don't see the meshwork of blood vessels anymore. This patient was supposed to go for amputation of that hand after we embolized him. However, once he saw that his bleeding has stopped, he declined to give consent for the amputation, and he left the hospital. He's not been back, so I'm hoping he's still well wherever he is. Next slide. The next case was a patient where a 7-year-old child who had bilateral retinoblastomas and had been on treatment for quite some time. The right eye had been enucleated, and so she only had the left eye, and the left eye was was a group D on salvage. Basically, the vision was minimal, but there was still perception of light, and so the ophthalmologist wanted to try and salvage or retain this eye, even with that little perception to light. So basically the surgical option of enucleation was not the option that was chosen here, and they sent her to us for embolization. So what we do for retinoblastomas is intraarterial embolization, where we give chemotherapy directly into the blood vessel that is supplying the retinoblastoma, the tumor within the globe. And so we did that, and go to the next slide. So again, here we'll just go through tiny catheter at the hip through the common femoral artery. We guide our hydrophilic wires and catheters all the way up to the carotid artery, the left internal carotid artery, and eventually to the ophthalmic artery. And then once we get to the ophthalmic artery, we are able to give the chemotherapy directly into the eye. Next slide. And so this is an angiogram. If you can play it, you can see the catheter here is within the carotid artery, and we are opacifying the vessels of the brain through that catheter. And if you look at this region where the eye is expected, you can see that tumor blush where the retinoblastoma tumor is. And of course, once we give the chemotherapy intraarterially, you start seeing a reduction of that tumor blush. Next slide. So this child we were able to save that eye. The next case is a 64-year-old male. This one, he was a hypertensive, poorly controlled, just like most of our patients. And he had been sent to us from cardiothoracic surgery. And this is because he had chronic lower limb ischemia, and he had already had amputation, auto amputation of the big toe. Now, the issue was that he had a wet gangrene, and he required to go to theater for amputation. However, the gangrene had not demarcated, and so they sent him to us so that we can try and do an angioplasty, so that we can we can at least enable the gangrene to demarcate better. Next slide. So this is how he looked when he came. You can see the thumb was already long gone by then, and the skin was darkened and edematous and all the way up to around the knee joint, but there were still some feeble pulses that could be felt. Next slide. So ideally, you would want to do an amputation for a limb as low as possible. You want to retain as much of the limb as possible. And so if you look at these CT scans, the 3D formats, so yeah, just there, you can see in one limb, you can see the superficial femoral artery. The femoral artery come down. You can see a bit of constriction at the knee joint there, at the popliteal artery, but then the arteries to the leg then reconstitute. But now on this other side, you actually see an abrupt cutoff just at the distal femoral artery there. And then, you know, the arteries to the leg reconstitute much lower down through tiny blood vessels. So whatever is supplying the lower part of the leg is little and is not sufficient to sustain that limb, but also it's not enough for him to get a gangrene that with a proper demarcation. Next slide. Sorry, gone back. Yeah. Yeah, so if you look here, you can now see it on the angiogram. Once our catheter has come down, we give contrast, and you can see exactly just what the CT scan showed, that abrupt cutoff at the distal femoral artery. And you can see tiny blood vessels now feeding the rest of the leg. Next slide. And here, this is after balloon dilatation. You now see that the blood vessel has opened up, and you can see contrast coming down through the vessel into the tibial, the anterior and posterior tibial arteries. Next slide. So case number 5 was a 50-year-old female. This lady had she had bilateral carotid body tumors. And she had already had surgery for the carotid body tumors 2 years prior, but now it was again enlarging. She was developing a hoarse voice following the surgery. She had developed a hoarse voice following that previous surgery. Next. These are just images to show you those lesions. These are CT scans of the neck, and you can see enhancing lesions or bilateral in that region, but larger on the right, where she was having symptoms. Next slide. So we did a 4-vessel angiogram, and usually we are able to demarcate the blood vessels supplying the tumor. However, in this patient, we were not able to find them, but that is because she had already undergone surgery. So we couldn't find the external carotid artery, which is what primarily tends to supply the carotid body tumors. And so on the left side, where she had not had surgery, we could demonstrate the feeding artery. So we were able to do what is called embolization of that the left side. And then on the right side, where we could not demonstrate the blood vessels, we were able to go now percutaneously. That is just directly. We go with ultrasound and put needles into the tumor, into that lesion, and then inject what we'd call a sclerosant into the lesion. And we are doing it under fluoroscopic guidance to make sure that the medication or the sclerosant that we are giving is limited to that tissue, to that mass, and it doesn't go anywhere beyond that. Because of course, if whatever we are using to finish that tumor goes into the brain or to another distant area, of course, it would cause issues. So we were able to do that, and the whole lesion was covered with sclerosant. Go to the next slide. And so you can see here, we know the area of the tumor, but we could not outline the vessel supplying the tumor. You don't see that typical tumor blush on these images. Next. And so you can see our needles, we put in these needles using ultrasound guidance. So these needles are going directly into this tumor. And what is dark here is our sclerosant therapy. We were using alcohol, and we mix it with contrast so that we're able to see where it is going. And once we put in our sclerosant, we did a final angiogram, and we were not able to see any tumor blush. Next, so this patient was saved, and she didn't have to go to theater for for that lesion. This one was a patient who had a lung abscess, had developed a lung abscess following a stab wound injury. And this is an ultrasound of the chest, and you can see that well-defined hypoechoic or anechoic lesion with internal echoes and debris. Next slide. And so under ultrasound guidance, we're able to put in a tube. This is the pus we drained, and this is the residual abscess following drainage. And the patient, this is done as an outpatient procedure, and the patient just comes in, gets it done, and goes home without a tube and feeling better. Next. The final case here, this was a lady who was a known diabetic hypertensive with chronic kidney disease. She had already been amputated previously due to peripheral artery disease. As you can see in this image, she had already had the amputation. And then now she had multiple dialysis access failure. She had right subclavian. If you look here, you can see there's a scar from a right subclavian dialysis catheter. She had another one from a left subclavian dialysis catheter insertion. And this wound right here in the middle was an attempt to put a dialysis catheter through the jugular, the internal jugular, and that had also failed. So you can see she has a catheter already in the femoral artery, but it had already dislodged. You can imagine that most of this, all of this length up to around there should be within her veins, and it's right out here. Actually, we just removed the dressing, and it was just seated. It was just lying on her. So next. So she had not dialyzed for a long time. Sorry, I think you've gone far ahead. And we are able to, using image guidance, we are able to find an access for her. We are able to balloon the vessels that are stenosed from previous access sites, and insert a dialysis catheter and allow her to continue care. Thank you. So that was just a brief example of some of the things we do, but we do other things beyond this. We are able to intervene for patients for women undergoing suffering from infertility. We're able to do fallopian tube catheterization, which is also a day case, and we're able to open up those blocked tubes. We also do uterine fibroid embolization for patients who would want to retain their uterus or do not want to go to theater. So we also do it for pre-surgical preparation, especially where patients have big fibroids and the surgeon is expecting a lot of hemorrhage. We're also doing tumor ablation, where patients have different tumors in the bones, in the liver, lung, and we're able to put in our probes there and burn or freeze the tumor. We're also doing embolization of hepatocellular carcinoma, what we call TACE. We intervene in the acute settings, of course, like for example, where we have patients with upper and lower GI bleeding. You know how those patients present. It's usually catastrophic bleeding. They are vomiting blood. They are passing fresh blood per rectum. We're able to go in and embolize. We also do varicose vein ablation, coiling of aneurysms, even in the brain. Drainage of biliary drainage where a patient has obstructive jaundice, nephrostomy tube insertion where there's obstruction to urinary flow, gastrostomy tube insertion without having to go through open operation. We also fix the other central lines as was discussed earlier. So that's, thank you for giving me the chance. I hope I've given an overview of just some of the things that we're doing in IR and specifically in KNH. Thank you.
Thank you so much, Dr. Wangari, for that presentation. Some of those cases were very amazing, most of them. Some of them, I think you're very brave in doing them. But as you can see, these cases that are being done are actually life-changing procedures. Some of them are actually emergency procedures, which if they are not done, I think patient outcome might not be that great. So thank you so much, Dr. Wangari, for that amazing case presentation. Now we're going to move on to the future of IR in Kenya by Dr. Murai. Dr. Murai will tell us what the future holds for IR in Kenya. I think you can take it over, Dr. Murai.
Yes, thank you for the opportunity. Dr. Bashir, thank you for the introduction. I'll be looking at the future of IR in Kenya. I've specified in Kenya because some of these procedures are already being done in other centers. We have some of the challenges that are limiting both at equipment level and also at a personnel level. In some countries, some of the things I'm going to talk about, people have gone sub-specialization in IR, which we are yet to get there. Yeah, next slide. Yes, I'll want to look at the musculoskeletal system, and in musculoskeletal system, IR has a role in multiple areas, touching on several specialized units. Yeah, next slide. And I want to start with vertebroplasty and cementoplasty, kyphoplasty. Basically, these are procedures that are done, a percutaneous technique developed to treat vertebral hemangiomas, osteoporotic compression fractures, and osteolytic tumors, metastasis of the spine. Someone will want to know why, when you're talking of metastasis to the spine, why we should intervene. But remember, some of these compression fractures come with a lot of pain and some limiting effects, both pain because of nerve compression and also just from the bone itself. And this is done to carefully selected patients that help in reduction of pain in almost 80 to 90% of patients. On the right is just an image of a patient who had a metastasis. And you can see initially there was a loss of that vertebral body height, but with vertebroplasty, you are able to regain the vertebral body height, and that's the function and loss of reduction in pain. Next. Next slide. And then we have the same thing being demonstrated here. And basically, you start by under image guidance. You get there is a balloon. You get your guide needle that is attached to a balloon. Then the balloon is inflated to the desired height. Then within the balloon, the cement is injected to lift up the vertebral body to desired height. Next. Yes, the same being demonstrated here. The first is to elevate the vertebra to the desired height. Then the cement is injected. Then after that, you can see the final image with the cement in place. Yes, next. Yes, we have before you go to that, there was a slide behind there that is talking about sometimes some of these bone tumors, especially when you're looking at the long bones. Back again. when you're looking at the long bones, you can do, especially if you have a bone lesions, intraosseous lesions, either malignant or benign. Sometimes we can do cryotherapy, and after cryotherapy, you do semen injection after you've done cryotherapy to the tumor. And basically, cryotherapy is one of the ablation techniques used. Ablation, we have the chemical and thermal. Thermal, we have a cryo where we are using you are basically freezing that particular tissue to very low temperatures that end up causing death of that tissue, or you are applying very high temperatures that end up also causing the death. And the space is then the space that is left behind. You inject cement. Yes, you go forward. Next. Then we have the joints, and basically when you are looking at the joints, we have multiple joint pathologies, and embolization of inflammatory joints is one of the treatment options that is being practiced. And when we are looking at these inflammatory joints, we are looking at osteoarthritis, frozen shoulder, which is basically adhesive capsulitis, and overuse injuries, that is tendinopathy and tendinopathy. And this one, basically, you go to the next image. You are basically trying to deprive the inflammatory tissues of that joint because of the increased angiogenesis. You are trying to deprive it of the blood supply, and that reduces the rate of new vessels formation, which comes with a lot of sensitivity, nerve sensitivity around the new vessel development. We go to the next image. Yes, this is basically what we are talking about, and this we are looking at the knee. The first image is a diagram demonstrating the vessels that supply the knee. We have the superior genicular arteries, superior lateral and the medial, and then we have the inferior lateral and medial genicular arteries. And in the first angio image, you can see after super selection of that genicular artery, you inject, and there is a blush. Basically, there is an increased angiogenesis around that point. And most of these patients will be able to lateralize the pain to where there is increased angiogenesis. So as you do your angio, you can actually examine and see where there is a tumor blush. There is a increased vasculature, not really a tumor blush, and that can be closed off. When you are closing, your interest is not to close off the whole vessel. That's why you have to go distally and try to embolize just at the point of angiogenesis, where the new vessels are being formed. Next. Yes, the same can happen to the shoulder where you go to the subclavian artery and then super selection to the feeding shoulder joint, that arteries that feed the shoulder joint, and these can be catheterized. And on examination, angiographic examination, you can see likely the offending artery, and that can be closed off. Next. Then there is intercutaneous fistula when you are looking at the GI applications and the use of this technique, sealants such as fibrin glue and just glue cyanacrylate has been in effect since 1990s, and this is for low output fistulas. We are looking at less than 500 mils. They can be used, and basically you identify the fistula, clean it, and then with a catheter you can cannulate and inject glue to speed up the closure of the fistula. Next. Then we have in portal hypertension. My colleagues have touched on this. It's an area that very soon this service will be available. I'm hoping by the end of the year we should be able to offer this. And we are basically portal hypertension is increased in portal venous pressures. And they are most of the time when it's defined by venous pressures more than 10 millimeters of mercury. But this patient has a potential of bleeding when the pressures go beyond 12 millimeters of mercury. And these are some of the prehepatic causes of portal hypertension. Next. And then we have the hepatic and post-hepatic. And of note, I'll want us to look at the first cause of the hepatic liver cirrhosis. We have enough. There are a lot of patients we normally get with this particular cause, cirrhotic patients with portal hypertension. And also we have the post-hepatic, and most of the time in our setup, you find most of those patients, you have the Budd-Chiari syndrome. Next. Yes, and some of the complications that will require management, we have the ascites, the varices, esophageal gastric. And then we have gastropathies, hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, and congenital congestive splenomegaly and hypersplenism. These are some of the complications, and for those who practice in our wards, you've met these patients. The diagram on the right is basically looking at the anatomy and collateral pathways that with the portal hypertension, they will dilate, causing bleeding with other pathologies that come with them. Next. Yes, these are CT scan. Basically, the first image we are looking at the esophageal varices. Then we have the splenorenal proliferation of the collaterals, the same being demonstrated in the coronal image. And also you can see sometimes even we have the retroperitoneal pathways being opened up. Next. Some of the options we have tips, basically transjugular intrahepatic portosystemic shunt. And this is aimed at, it aims at reducing the portal venous pressure, where you create a shunt between the hepatic vein and the portal venous system. And this shunt is done endovascularly, connecting the two vessels to reduce pressures within the variceal system. Next. And then we have also balloon occlusion, retrograde transvenous, or obliteration of the varices. Basically, you get through the portal system and then do balloon occlusion of those varices and inject a sclerosant. It is an alternative to TIPS, but most of the time also it's used as stopgap measures before the creation of a TIPS shunt. Or the two of them can be used all together. Next. Then we have a hemorrhoid emboloidal technique. This is basically embolization of hemorrhoids. This is already being offered in our country and in this town, Nairobi. It's not actually a new technique. Yes. And basically, you get into the superior rectal artery and embolize the superior rectal artery. Sorry. Next. And then we have the bariatric embolization, and basically this is to suppress the ghrelin production. This is a hormone that is a hormone that will remind your brain that there is you are hungry or you are satisfied, depending with how the production. And basically, what this entails is that the center of production in the stomach is within the fundal region, and that area is supplied by the left gastric artery. You can go embolize the left gastric artery, which will suppress that production of ghrelin hormone, and this will reduce will reduce that urge to wanting for people who are looking at weight or losing weight to urge to eat or to feel hungry, and thus reducing the in the long run it leads to loss of weight. Next. Yes, basically this is demonstrating the process of getting into the part of the stomach that the left gastric artery supplies, and the other images are angio images, selection of the left gastric artery, then embolization. Next. Then we have my colleague has touched on dialysis catheters, but you know the long stay of dialysis actually in some centers is fistula creation, which is a surgical procedure, but currently there are tools that are used. Most of this system is commercially available, used as a single or double catheter approach or dual catheter approach, respectively, with also using radiofrequency tools to create the fusion channel between the arterial and venous wall. This one is used in combination with the EVAS, the endovascular ultrasound that will guide the direction and the distance from the vein to the artery. And then the thermal resistance anastomosis device is a single catheter system creating the arteriovenous fistula by direct puncture of the deep communicating veins and the proximal radial artery. And this creates a channel that with the time as it matures, the patient can use for dialysis. Next. Then in oncology, there are a number of services IR can offer. Right now, the microwave ablation is available in our country and in Nairobi. This one can be used. Where then we have radiofrequency ablation, we have cryo, then we have focused ultrasound, which is also available right now. And then we have embolization that we've been offering for tumors. Then the variable basically induce tumor necrosis, thus exposing the tumors to antigen, and basically stimulates physiologic immune response, some of them. And the majority is basically you are destroying the tumor cells within that particular focal targeted area. Next. Yes, this is a field that I would also want to touch because it's one of the things we cannot run away from, but it has demonstrated great potential in wide variety of application in interventional radiology. Though adoption in IR is a bit more complex compared to diagnostic radiology, and because IR depends on unstructured data. Most of the time, some of those procedures you can never say what you'll do until you get into that vessel and make a decision while there. But support of decision making and outcome prediction improvement in fluoroscopy, ultrasound, CT, and MRI, specifically in field of IR, has also been investigated. Next. But IR represents a significant boost for fusion imaging and stimulates reality, especially reality robotics and touchless software interactions and virtual biopsies. Though in most of the text I've looked at, most of people believe that the procedural nature of IR is a bit heterogeneous and complex, and lack of standardization slows down the process of adoption of AI in IR. I think that will be my last slide. Thank you.
Thank you so much, Dr. Murai, for taking us through those innovations, especially you've taken us go through patients who have knee osteoarthritis, embolizing for knee osteoarthritis, which can be extended to plantar fasciitis also, and all the way to hemorrhoids, which can also be embolized instead of a surgical option, and finishing with AI. I think that was a good overview of what we can have in the future. I would like to introduce Virginia, our nurse, the nurse in charge in interventional radiology at Kenyatta National Hospital, to take us through what nursing is all about within the interventional radiology unit. So Virginia, welcome.
Good evening, colleagues. Can you hear me?
Yes.
Thank you. Yeah, my name is Virginia Jenga, a nurse working in radiology. Thank you very much, and I appreciate my presence here. And I'll go straight to the presentation. Sorry for that typo. That is supposed to be nursing care in IR. So, who is an IR nurse? This is a highly specialized nurse, trained and experienced nurse that assists in interventional radiology in minimally invasive procedures. We can move next to the other slides. Next slide, please. This is meant to be the general overview of how IR nursing at KNH has evolved. Just to mention is that a few years ago, the role of the nurse was not clearly outlined, and there could be just a few nurses allocated there to oversee a few procedures like in IR, MRI, CT, and so on and so forth, and this was not very consistent. When you look at the issue of IV access, majorly it was done by the radiographers, and maybe that could also explain why we used to have many cases of extravasation, and especially after injection of the IV injection of the contrast media. But about a few years ago, we've witnessed the rise in the numbers, generally in radiology, and specifically in IR, where we have usually a minimum of 3 nurses supporting our highly specialized doctors and the radiographers to perform these procedures. Next slide, please. So currently, just as an overview, is that we have about 8 nurses in the radiology department. We cover all those areas as I've mentioned. And in IR specifically, we do an average of about 20 cases. Of course, that is when the machine was up and working. Currently, the cases have gone down. So, and of course, we've seen the cases of extravasation significantly going down. In terms of resuscitation and management of emergencies, we've also seen a very great improvement with the numbers of we are having. So, the role of IR nurse, allow me to just classify the role of IR nurse into 3 major roles, that is pre, intra, and post-op. And this being a surgical suit, pre-operative or pre-procedure responsibilities of the nurse. One of it is that we do the patient assessment at the triage area. We take history, we take vital signs, we do consent verification, just to ensure that maybe during the clinics or previous contact of this patient and the doctor, that the consent was acquired, or if not, we ensure that is done before the procedure. Then we also start IV lines. We do pre-medication if need be, and we do patient education. When we go to the intra-procedure, the role of the nurse is very vital because we do monitoring of these patients, and especially the patients who do not require sedation. That means the anesthetist is not there. So it is the role of the nurse to connect this patient to the monitor and actually monitor the vitals through the procedure. If need be, there's need for support with oxygen, we do that. We also do the documentation intra-procedure. For the cases that require anesthesia, we are there assisting the anesthetist in sedation of these cases and also monitoring. Provision of medication as need be. We also manage pain in collaboration with our IR specialists. Intra-op, we also do scrubbing, and especially where the IR specialist doesn't have assistance, so you become the first assistant, and therefore that is scrubbing in for the case and ensuring sterility throughout the procedure. In equipment handling and management of those cases. Post-op, the role of the nurse comes in handy where we do recovery of these patients. Some of them are unstable, very unstable and very sick, and especially our oncology patients. We observe the vital signs. We monitor for any complications like bleeding, allergic reactions, changes in the hemodynamics or the vital signs. We do patient instructions post-procedure in collaboration again with the IR specialists, so that the patient gets the instructions very well, especially on the care of the drainages for those who are going home, care of those surgical sites, and the tubes for the ones who are having the nephrostomy tubes insertion, and so on and so forth. So we can move on to the next slide, away from the role of the nurse. Those are just some of the roles that the nurses play in the IR suite. So some of the challenges, if we may touch a bit on the challenges that we've experienced, is that we have had a shortage of nurses. We've also had frequent reshuffles of the nurses who have been actually had hands-on training. So that always takes us back in retraining the new nurses that we receive. We've had inadequate preparation of these patients, whether they are coming from home or they are coming from the wards. You find a patient who was supposed to be NPO, they've fed, and some of these things delay our procedures and even interferes with our cutting times. So patients also coming late, and the challenges of billing is also another hindrance to our starting time, and lack of adequate machines or frequent breakdown of our machines. We've also had a very limited space to recover our patients, which is also a concern because we need a better PACO where we can monitor our patients adequately. So next. So as the nurse representing the IR nursing, these are our recommendations, that there should be sensitization, more sensitization on the role of the nurse in IR and in radiology generally, for people to be able to understand exactly what the nurses do in radiology and appreciate the role of the nurse there. Nursing students should also be allowed to do their rotations there, to just have a touch on exactly what are you supposed to do with the patients when you are located in radiology. Then the last one is a tall order, though the baby steps have kicked on. That in Kenya, we do not have specialization in IR nursing. But the world out there have that provision, and this is actually a training, and especially post master's level, so that the nurses working in IR are at par with the highly specialized doctors and the radiographers working there. So we need to think on those lines to ensure that our definitely I've mentioned about extension of the PACU or provision of somewhere we can recover our patients. Then definitely I would recommend that we have more nurses in IR to be able to offer the really needed support. I thank you. That was my presentation.
Thank you so much,
Any
Virginia.
questions?
Yes, thank you so much, Virginia, for that presentation regarding IR and nursing in IR. Nurses play quite a vital role in the interventional radiology suite. As you have seen in the whole presentation, I think we handle very sick patients. Some of them are actually having bleeding with variable disease processes. And I think the nursing team is very vital in achieving the outcomes that are being achieved in the interventional radiology unit. So I think it's time for a Q&A. I think we'll take the next maybe 10 minutes looking at what has been. I think there's some questions in the chat box. We can start with the first one. I think either Dr. Mugambi or Dr. Wangari can answer this. Is IR a complete alternative therapy for the common fibroids and tumors?
Thank you.
Dr. Right. Bashir, but I think in treatment of the fibroids, we may not say it's the treatment for fibroid, but people change, things keep on changing, and with the new inventions, actually, we are finding people are tending to come for more fibroid embolization compared to myomectomy. One, you go home with no scar, the stay in the hospital is less. The people, we had a notion that it was affecting fertility, but it doesn't. So it is a common trend, and I think maybe in the next 5 years, you'll find more referrals for uterine-artery embolization for the treatment of fibroid. Not only for the treatment of fibroid, but for the treatment of quite a number of cases like placenta crater and intractable postpartum hemorrhage, where you find somebody now, instead of retaining the uterus, you find now, if it is intractable, you cannot get to maybe embolization. The only option is removal of the uterus. So it depends. One, the patients we get few vertical referrals, but we are getting more of horizontal referrals. You treated somebody and then somebody tells you, My neighbors have said I was pregnant. They asked me where the baby is. And you find out this person, he finds a patient or a friend who has the same problem, we will going to refer the same patient for the uterine embolization. That's it.
So the next comment I think is the next question was what is the referral protocol to KNH and when are the clinic days? I think Dr. Mugambi had touched on this. The clinic day is on Wednesday. And I think the referral protocol is to write a consultation to the interventional radiology clinic, if I'm not wrong.
Yeah, you're right.
So the next question is, does interventional radiology have a role in, say, esophagus or, say, stomach? I think Dr. Wangari can take this one.
Yeah, thank you. Currently, the options in treatment are not many, but we do participate in the palliative care. For example, if a stent needs to be inserted, esophageal stent, we can do that. Also, we can do the gastrostomy tubes where there's a feeding issue, and most of those patients tend to be quite cachexic, and maybe they may not be candidates for general anesthesia. So in that case, we can come in and help with the gastrostomy tube insertion for the C esophagus. For C stomach, then they would probably have to go to theater. In the developed world, they are doing more treatments, including embolization of those esophageal tumors, pre-surgical. So hopefully that's one of the things that we shall be growing into, just to support oncology care in the future.
The next question, Dr. Murai, what are the adverse effects of bariatric embolization?
Yes, one thing, when you're looking at embolization, one of the risk factors is non-targeted embolization. And two, when you're doing bariatric embolization, also remember there is a target someone might have, and you can easily find that you are going beyond the target weight someone might have, beyond the target weight, basically, to a point that now, again, other measures have to be taken for sustainability. Thank you.
I think, Bashir, let me add something also on bariatric embolization.
Okay.
Is the other common thing is that if you are going for bariatric embolization, don't think of bariatric surgery, because you're knocked off the major artery, which supplies the the left gastric artery. So later, if you really want to reverse back to bariatric surgeries, it may not be possible because of the devascularization of that region.
So I think we can go to the next question. I think this is for Virginia. Is there an institution in Kenya that is currently offering training for IR nursing? I think you briefly touched on this.
Not any for now, but we've initiated that discussion with the University of Nairobi School of Nursing. We hope to get there. Thank you.
So the next question, I think maybe I can rephrase it. I think someone was asking is, how is IR involved in actual tumor management? I think Dr. Mugambi, you can take this one.
Yeah, tumor management, IR is 2, 3, I would say 1, 2, 3 roles. There's the diagnostic part of it, where we do image-guided biopsy for confirmation of the tumor. And the second part of it is we do like embolization, like what Wangari talked about, transarterial chemoembolization or transarterial radioembolization, where we are containing, or sometimes, most of the time, we are completely treating the tumor. And then there's a role whereby now we do this supportive treatment. For example, if you have cancer of the cervix and there is obstructed uropathy, that's you're not passing the urine, your kidneys are failing, we are able to do percutaneous decompression of the kidneys, and then also we are able to do what we call DJ stenting. That's we bypass where the obstruction is, and then you are able to drain the kidney well. You get your kidney goes back to its normal function, and then you can get now the treatment, chemo, radio, etc. Then also on top of that, we have also that supplementary role whereby, for example, you have a cancer of the esophagus, we are able to put in a stent, and or we put in a PEG, percutaneous insertion of the feeding tube, whereby you are able to treat, you gain your weight, and then you get treatment. So it's diagnostic. We have management, or where we are going to either treat the tumor or we slow down the progression of the tumor, and the supportive part of it, where we do supportive care like drainage of the kidneys, or if you have biliary obstruction, we drain the bile so that you can get the appropriate treatment.
I think there's an interesting question. Where does the farm tech come in with IR, Dr. Wangari?
Thank you. I think for IR, all the supportive services, just like you'd have in any theater, come into play, because even in IR, we are managing quite a number of medication. We are managing, we have the consumables, we have, and of course, patients also develop adverse reactions to medication, just like anywhere else. So I think for IR, the only unique thing is that it is a new part of medicine in this part of the world, but all services, just like in any other unit, would need to support the unit for it to be for our work to be successful.
I think we'll take the last question, which I think there's a lot of interest in it. There were several questions about fibroids. So I think I'll leave this to Dr. Wangari. Someone is asking, are there any studies comparing embolization and myomectomy for fibroids, especially in relation to future pregnancy?
In treatment of any condition, I think there are always options depending on what, the kind of symptoms somebody is having. So fibroids, we come into the management of fibroids in different areas. So just like the obs-gyn, if they are small and they are asymptomatic, like most women have, we won't do anything about it, just like the obstetrician, the gynecologist, who will also not touch them. And then where they start being symptomatic, that's where we come in. So specifically, patients who have that feeling of pelvic heaviness, excessive bleeding, very heavy menses, severe pain during menses, the bulkiness and like frequency passing urine. Now those ones become candidates for intervention, and the intervention can be medical, it can be surgical, and now it can be interventional. So there is a patient who would want to retain their uterus because maybe they've not had children, or they don't want to go for surgery. Those ones are good candidates for embolization. We also find there are patients who have had previous myomectomies. The surgeon is not enthusiastic to go back into that abdomen, especially being medical people. You know, patients tend to get those adhesions from previous surgeries. Those ones also now become good candidates for fibroid embolization. You know, so I would say the advantage that embolization has over the rest is that when we give the embolic agent into the artery, it will cover the uterus, you know, kind of homogeneously, as opposed to maybe the surgical option where the surgeon can only access fibroids that are maybe subserosal or submucosal, and they may not be able to have vision of all the, you know, the ones which are within the myometrium. So sometimes that's why you have patients telling you, I went for surgery and then they've come back. But most of the time they may not have come back. It could be the tiny ones which were not visible within the myometrium during surgery, and you know, those ones continue to grow. So for embolization, you kind of cover everything. So I would say each intervention, be it surgical or medical or interventional, each patient is different, and you know, the choice is based on what you discuss with your doctor. What is your current situation at the time? If they are giant fibroids, then those ones become like more they would be served better by a surgical option rather than the interventional option. Sometimes you need a combination of the two, where let's say you have giant fibroids, there's a risk of heavy bleeding during surgery, so we can embolize, and then the surgeon now goes in and does the rest of the work. So I can't say that there's one answer that fits everyone. It's always in medicine, patients vary so significantly. So I would also say even the choice of intervention would vary depending on the patient presentation. But having said that, at least for most patients, what we do see is that bleeding, heavy bleeding, and period pain and pelvic pain, those ones reduce significantly within the first month after embolization. For most of them, they'll tell you the period is normal or even minimal bleeding. The next period after embolization is usually minimal bleeding. And then for the heaviness, you know, the patients who have kind of a uterus at around 20 weeks, 24 weeks, the size of the uterus reduces by at over 50% by 6 months, and of course it continues to reduce after that. So yeah, so there are those patients who would benefit more from the minimally invasive, and there are those who surgery would be the first option, and it's all on a case-by-case basis.
I think
Bashir, if you have sometimes I really would make a comment. Do you have time?
go ahead. I think
Okay,
we're
fine.
about
I've seen a
yeah.
question there about somebody saying doesn't know what IR does, and we don't do only what he really outlined here. We do so much. It's only that would you say this is a procedure actually they have been done before. It's only that we're having them now in our country. We do so much, and our management is not age limited. We do intrauterine interventions, and we can do our intervention to somebody who is 100 years and above. So we don't have that age limitation. I say our patients are 1, 2 years and above. No, we even start from before conception, because we have things like infertility issues where we open fallopian tubes which are blocked. We have vasogram, and the next time we are going to get to see whether we have a those sperm duct which are blocked. We want to find ways of unblocking them. And even if you're intrauterine, we have procedures we can perform. Murai did something just, I think last year, where there was an exchange of intrauterine blood transfusion. And two, if, for example, you're getting IVF, you get maybe more fertilized egg implanted than normal. We have selectively, I mean selectively, because I think it's difficult for somebody to carry more than 8 babies. We have selectively getting some of them out so that you leave you with the ones you are able to carry. Then also we have issues where you find that babies have so much congenital malformation, and you find you just are not a viable baby. We have ways of sorting that out. So our procedures, there are very many, and we don't have an age limit.
Thank you, Dr. Mugambi, for that comment. I think we are past 15 minutes from our time. It's been a very interesting presentation, and I can see there's a lot of interest in interventional radiology. This is something that is there, and I think it's available in also in Mombasa, in Eldoret. So the scope for interventional radiology in terms of where it's being done, I think it's being done in some of the major cities here in Kenya. And I would like to close the meeting, and on behalf of everyone who has presented today, and everyone who has attended, I thank you for attending our session today in interventional radiology in patient care. I also want to send my sincere thanks to Dr. Mugambi, Dr. Wangari, Dr. Murai, and Virginia for their presentation. Thank you all for being part of this session, and see you next time in our webinar. Thank you very much.
Thank you, Bashaib.
Thank you, Dr.
Thanks. Good night.
Good night.